Okay, so the next presenter is Allen Cheng. So Allen is the Director of Infectious Diseases at Monash Health and a Professor at the School of Clinical Sciences at Monash University. He was previously the co-chair of ATAGI and the chair of the Advisory Committee for Vaccines. He was recognised this year as a Companion of the Order of Australia. Today, Allen will be talking about two topics for us. The first one is selective decontamination of the digestive tract in patients on invasive mechanical ventilation, and the second is C. difficile. So there'll be an opportunity, hopefully, to ask Allen questions at the end of both of the presentations.
So before I start, are there any hospitals that are actually using selective digestive decontamination? And can you put up your hands if your hospital is using it? Well, I can go home then. So I think there's actually no licensed product, I think is one thing. So obviously there's been the Sudoku trial, but after that finished, I don't think it's been widely used. This wasn't my topic. Josh Davis was the primary reviewer for this. But I'm presenting on his behalf. So in antibiotic 16, there wasn't any recommendation. It wasn't on the radar, although it had been used in other countries. And basically, the recommendation says that it has to be an institutional decision whether to use it or not, and to seek expert advice. So maybe just to backtrack a bit of background, so selective digestive decontamination is both oral and nasogastric or enteral antibiotics. It's tobramycin and nystatin down the gut, and then intravenous ceftriaxone or ciprofloxacin. So pretty significant antibiotics. So the Sudoku trial, which was done in Australia, showed a non-significant decrease in mortality, and during the trial they didn't detect any increase in antimicrobial resistance, and as has studies in particularly the Netherlands, where this has been used for a long time. But I think the Netherlands is not Australia, and there is a note that we may want to consider what the prevalence of pre-existing AMR is. We'll just point to the grade assessment of evidence that was actually published in the accompanying meta-analysis. So the meta-analysis actually suggested that there may be a mortality benefit, and it was about an absolute benefit of about 2%. So for intensivists, that's a lot. And I think the general feeling among intensivists that it was probably a good thing to do, and the general feeling among infectious disease physicians it probably wasn't. So we pick out the evidence that we want to see. So in terms of this is the grade's summary of findings, which actually is probably pretty accurate assessment of the evidence to say that mortality, there's a moderate certainty of evidence. There is an inconsistency between the various trials. And then in terms of the potential to generate antibiotic resistance, the confidence in that conclusion was assessed as very low, because the trials didn't pick up a lot of, do very good surveillance for a lot of those endpoints. And I think in terms of arming yourselves against the intensivists if they come asking, and if you are like me, not a big fan of pouring antibiotics down into patients, I guess these are the four things that I would point to. So the biological plausibility doesn't really seem to work. If it is operating through reducing hospital-acquired pneumonia, why are we giving nystatin? If it's reducing GI bacteria, then why are we giving IV? And there is this possibility that maybe IV is actually just early treatment, and then perhaps we could be treating the ones that actually have pneumonia earlier. In terms of the evidence base, there are quite a lot of studies, but a lot of them are quite small, and most of the positive studies are actually older studies, and I don't think there has been a significantly positive study for about at least 10 years. And the reason for that may be that ventilator-associated pneumonia prevention is actually improving. There's less ventilator-associated pneumonia now, and there's probably less to prevent or treat. In terms of impact on resistance, there were in the Sudoku trial there were no outbreaks of CPE, and I think it would be most of our experiences that we have seen CPE outbreaks across Australian hospitals, and that does raise the possibility that maybe there was a selection bias in the hospitals that didn't want to participate in this trial. If you look at the definition of resistance in the Sudoku trial, it doesn't quite line up with the antibiotics that we use. So, for example, if they had I think it's a ciprofloxacin-resistant Enterobacteriaceae, that wouldn't be defined as AMR. Under that, it had to have 2 antibiotics. And then the meta-analysis, as I noted, had a very low confidence in the resistance outcomes. And then, even though the trial did say that there wasn't any change in the daily doses, it wasn't really, the way it was calculated may not have reflected true exposure, because if you're pouring it down the gut, then the antibiotics that the bacteria are seeing are probably quite a lot more than the defined daily dose, which reflects intravenous dosing. So just to go back to the recommendation again, the decisions about the use of SDD should be made at the institutional level, and they should come and speak to you. And so I might just, unless there's any questions, I might just move straight on to C. diff. So the old recommendations, this is a bit small to see, but the old recommendations had metronidazole as number 1, vancomycin as number 2 for non-severe C. diff. For severe C. diff, vancomycin, and then for the first recurrence, vanc and then fidaxomicin as number 2. And there was mention of fecal microbiota transplantation, but it was there wasn't a lot of detail presented on that. The changes for antibiotic for the current edition is that we now recommend vancomycin as number 1 and metronidazole as number 2 as an option. There is a stratified table now for the first recurrence, and it really depends on whether there is a trigger identified, or is it really just a recurrence, and then what was used for the first treatment. And now fecal microbiota transplantation is now sort of out in bold. This is pretty much where it was before, but just trying to make it a little bit more explicit. So the path to this is a little bit more complicated, because there had been ASID guidelines, and Jason will remember all the headaches we went through with that last one. But Anthony Longatano and Eugene Athan happened to be doing a systematic review and grade assessment of the evidence at the same time that we were writing this, so we thought it would make sense to try and to coordinate this. Emma Bishop's actually doing a PhD in this area, and Emily Tucker obviously is involved in the South Australia Biobank, so we did consult them as experts too, and thanks to both of them for very helpful advice. Other things that had changed since 2019 was the withdrawal of bezotuximab in Australia, so I don't think you can get it anywhere anymore. Fidaxomicin is still expensive and obviously not available widely outside of hospitals. And we also were a little bit concerned about the potential or the availability of oral vancomycin. Obviously very easy to get in hospitals, but in community pharmacies it would be still very difficult to get. So the data that drove the change in recommendations were the meta-analyses, which really suggested, originally we sort of knew this, that when you consider them all comers, vancomycin does appear to be better than metronidazole for all causes, but we really thought that was driven by severe disease, and we had recommended vancomycin in the past for severe disease. But now when you look at the stratified data, it does look like there is some benefit to vancomycin both for mild and moderate disease as well. And then the risk of recurrence was higher with metronidazole. So the summary of the GRADE evidence was from Anthony and Eugene was that metronidazole is inferior to vancomycin for clinical cure and shouldn't be recommended as first-line treatment, but it should be used as alternative therapy if first-line treatments are not accessible or appropriate. So this is basically what we've adopted, just noting that, again, vancomycin is probably not easily available in the community and metronidazole is readily available if they're in the community. It's obviously not going to be too severe. The other question was around fidaxomicin and vancomycin. In terms of just clinical cure, it does seem to be similar, perhaps a little bit better to fidaxomicin, but not statistically significantly different. But then the sustained clinical response seemed to be better with fidaxomicin. But, and the GRADE assessment was that fidaxomicin is probably better in terms of preventing recurrence, but similar for clinical cure. But this is where there have been some cost-effectiveness studies, but not done in the Australian context, and cost-effectiveness in the US is very different to cost-effectiveness in Australia. And because fidaxomicin is not on the PBS, I think the cost is still in the order of $2,000 per patient. So not on the PBS, patient would have to pay this. Vancomycin is on the PBS, again, with the issue that it's not easily available and not widely available. So we have sort of said that both vancomycin and fidaxomicin can be used in severe in hospital settings. And then in terms of FMT, there does seem to be good evidence now that FMT is better than vancomycin at least, and now with the advent of TGA-registered products, it's not the same, tortured process where you have to go and find donors and screen them and worry about, what else you might transmit with them. Thanks to all the hard work by Emily and the Biome Bank and others as well in making sure that there are manufacturing processes and screening processes. Still not simple. I think in my hospital we only did about 4 last year. It's $7,000 each plus the cost of the gastroenterologist administering it. So there is quite a lot of logistical hoops that you have to jump through, but it does seem to be better. So just to reiterate, we have swapped vancomycin and metronidazole. The treatment choice for first recurrence is stratified by whether there's a trigger or not, and FMT is the number 1 treatment for subsequent recurrences, but fidaxomicin and vancomycin are still available. So I'll leave it there and happy to answer questions.
Thanks, Alan. I think we have time for one question, and somebody's just got their hand up there. Madeline's just bringing the mic down to you.
Where was that hand, sorry?
Thanks, Alan. Is there any recommendations about the use of like a tailing course of vancomycin leading up to FMT?
Yeah, actually I might have to defer to Emily about this one. I think there is evidence for giving vancomycin, but not a tailing course, I think. But there is actually somewhere we have saying that if you can't get FMT, that for recurrences, tailing and pulsed courses are available. But I don't think we've put in any actual recommendations about those doses from memory.